Good morning. Thank you so much for joining us for our coffee conversations with Forge Breast Cancer Survivor Center. We are so excited to have Dr. Rodney Tucker with us today. He is going to be talking about palliative care and answering some questions that we all might have about it. What is it? What does it mean? And so forth. So we're very excited to have him here. Dr. Tucker, if you could introduce yourself to everyone.
Yeah, good morning. Thank you for having or taking time out of the morning for a coffee cup conversation. And thank you to Janita and Ford for the invitation. Always a pleasure to support the activities of Ford. So as Janita said, I'm Rodney Tucker. I'm, to go all the way back, I'm a native Alabamian. I'm from Gadsden, Alabama original, but I've been in Birmingham for actually 41 years. I'm a graduate, two-time graduate of UAB, undergraduate, and then medical school. And then I did a master's degree program in medical management at the University of Southern California. And so I've been in the Birmingham community quite some time. I'm board certified in internal medicine and hospice and palliative care, and currently in the division of geriatrics, gerontology and palliative care. So I've been at UAB for almost 21 years back on faculty. And so really my career over the past 20 years, now the majority of my career has been in working with patients and families with serious illness. So whether it's been in palliative care, supportive care, home care, hospice, that's kind of what I've been doing the bulk of my career. Currently right now, I'm the Associate Director for Diversity, Equity, and Inclusion for the O'Neill Comprehensive Cancer Center as well. So I wear a couple of different hats. So anyway, that's me. I'm looking forward to some conversation, coffee cup or tea or water
Yeah,
or whatever.
I got mine right here.
Drinking.
We've got like Forge cups now.
Yeah,
So.
little too early probably for other adult beverages, but yeah.
Yeah, and it sounds like you wear more than a couple hats. I'm gonna say that right there. Just a couple, like more like a few, several.
Yeah, a couple hats. That's okay.
But yeah, so excited that you are an expert in these things and you can talk about these things, and you're willing to do that with us. So first question is, what is palliative care?
Well, and that is a great question, and it's the most common, of course. I know that several of you on the call, I recognize lots of folks, obviously, and you've probably heard of palliative care, or maybe the co-term that we put with palliative care a lot of times, supportive care, which is very similar. So just to give you the formal answer, palliative care and palliative medicine is a specialty of medicine that really has only been developed over the past, we'll say, 20 to 21 years. It's a new specialty of medicine that focuses on providing care for patients and their loved ones, patients and families, in the 4 domains that make us, and I like to say 5 domains that make us human beings and patients. And that's the physical, the emotional, the psychological, the spiritual, and now even more looking at the cultural, aspects of what make us, human beings and patients. And so we specialize in, treating patients holistically in those areas. We focus on working as a team. So we're firmly, believe that it does take a team of social workers, pastoral care, psychologists, counseling, nutrition, physical therapy, massage therapy, pet therapy, art therapy, expressive, therapies to take care of a patient in that way. And our specialty is alongside curative treatment. So that's one of the things that, patients may be seeing palliative care for a decade, or they may see palliative care, closer as their illness, progresses. But we see patients alongside oncologists or cardiologists and things like that. So specialty of medicine, works in a team, focuses on holistic care, and provides that sort of extra level of care for patients and families. So that's the formal definition. The word palliative comes from a Latin word called pallium, which the palliums were the robes or cloaks that the popes and the high members of the Roman Catholic Church would wear. And basically those robes were meant to protect them from the evil humors. They were shrouded and cloaked in the palliums. And so that's where the word came. It was derived from a Canadian surgeon named Balfour Mount, who is still alive, as a matter of fact. So that's where the word came from.
Oh, and thank you for that history lesson, but also for telling us what palliative care kind of entails. But I know when I've discussed this with family members or just people who are just not well-versed in what palliative care means, when I'm trying to explain it to them, they'll be like, well, it sounds like hospice. So if you could just kind of break down to us the difference between palliative care and hospice for those who are trying to decide what's the difference between them and which route should I take?
Yeah. So hospice, particularly hospice in the United States. Now, it's a little different in Great Britain and Australia and some of the European countries, even in Canada to a certain extent. But hospice in the United States is basically a Medicare benefit. It is a program for patients who are entering the last, by Medicare definition, last 6 months, potentially last 6 months of life if their disease course holds the natural course. It's designed as a Medicare or an insurance benefit because it's not just Medicare. There's Medicaid, private insurance, pays for hospice. And so it provides care so that a patient and family can be equipped to have their loved one in the last stage of their life be at home or in a home-like setting. So hospice pays for the nursing care, the medical oversight, the medicines related to symptoms, the hospital bed, oxygen, all the things that it takes to care for someone in the home, nursing visits, 24-hour telephone, ability. So it's a benefit for patients who, are approaching a point, in their illness trajectory where they want to stay at home or out of the hospital. Okay. Many patients graduate from hospice, as we say. They move, to other care settings, or, they get symptoms under control, and then, they're doing better, and they come, on and off the hospice benefit. Palliative care particularly can be at any stage of a serious illness. It's not restricted to 6 months. It's not focused on, end of life. Works a lot with the family. So that's one of the big differences.
Thank you. And I appreciate you put it so plainly as well. And so when someone learns about palliative care and they have a serious illness, when is the right time to seriously consider it? Like, I've learned about palliative care, I have a serious illness or a family member does. When should they take that into consideration as it relates to including it in their lives alongside this?
I think it's a great question, and it's individualized because some folks, reach a point, at different times. The main place where we would say from a patient standpoint is when, a patient or the family may feel like we're missing something. There's something else. The quality of life is not here. The doctors say I'm doing great. The doctors say everything's in remission. The doctors say that we're going to watch. The doctors say that, we're going to wait for this next treatment, or let's keep doing the same thing. But if there's some aspect of life where there's any suffering, or there's any, we say something's just not right, and quality of life's being, impacted, or there's important decisions, to be made. So it's not an easy formula. We'll tell, meaning there's not strict criteria that says now you need a cardiologist, now you need a palliative care, physician. But when there's uncontrolled symptoms, when something's just not quite right, when you feel like the quality of life, could stand another set of eyes and partners to be able to. Now, with our physicians, a lot of times they'll say, well, I just don't know. I just don't know when to refer a patient to palliative care. I don't know when, the physicians a lot of times, or healthcare providers, will say, well, they're not ready for hospice. We say, okay, great. Well, if you've even thought that, then they're ready for palliative care. If you've even thought that somewhere along the way, if your provider or somebody says, well, they're not ready for hospice, okay, that's probably true. That's probably true. That's fine. But if there is some element of added extra layer of care, so we'll tell our physician friends, say, well, ask yourself this question. If you've got a patient in front of you that you're looking at and you're saying, okay, well, they're not ready for hospice, okay, which means you're not ready, nor can science tell you that they're in the last 6 months of life, then say, would you be surprised if this patient was admitted to the hospital in the next year? Would you be surprised if this patient was not in your clinic next year? Because the physicians sometimes will have a way of saying, you know, I'd be worried about that. Yeah, can't put my finger on it, but they look like they're, you know, having some troubles. That's called the surprise question. And we tell our physicians a lot of times, if you ask yourself that, it wouldn't surprise me if, you know, Mr. Tucker, you know, was admitted to the hospital. Wouldn't surprise me. Then say, well, let's do something different then. Let's get an extra layer of care. Let's get an added layer of support, you know, just to make sure that we've dotted our I's, crossed our T's. We're working with patients and families on goals, you know, things like that, so that whatever it is, 1 year, 6 months, 2 years, 3 years, that we're, again, providing the best holistic care, you know, for the patient. Doesn't mean they're going to give up anything. Doesn't mean they're going to stop any treatments. Doesn't mean that they're going to be pushed or pulled in one direction toward or away from something. It's just matching I call it matching the facts with the reality and with the, you know, patient's wishes and desires. Does that help, Janata?
Yeah, that helps a whole lot. That helps a whole lot. A lot of what I'm hearing you say is just how palliative is just support as you're going along this journey, and that support and that and all of those different types of plans that a person might make really are individualized. There's no like cookie cutter way to engage with palliative care, but in looking to engage with it, you know, when someone learns of it and is going through this transition in life, what is the first step that they need to take in order to take advantage of palliative care? I know that we kind of talked briefly about how hospice is more so on the insurance side, like there's just some logistics that you have to check off in order to participate with that. What are some things that someone would need to check off, or what's the starting point for palliative care?
I usually would tell folks the first, you know, checkpoint is check in with yourself and your family, you know, and say, what are you seeing? Because, you know, if a patient, you know, is really an educated consumer, a patient says, you know, I really feel like, you know, I need something else. I really feel like, you know, maybe I should see, I heard about palliative care. I went to a coffee talk. I, you know, knew of a family that was in the hospital, you know, and you bring that to your family can sometimes have the same reaction, because the family may look, you know, the mother may look at the daughter, or the daughter may look at the mother and say, what are you talking about? You're not giving up. We're not giving up on you. You're fighting. You know, so the first thing is check in with your family and say, this is what I'm experiencing. You know, this is what do you think? Because the observation of the family is extremely important, because they're with you. You know, a lot of family, you know, they're with you, they're observing these things. And then check in with your closest medical professional. So whether that's your primary care doctor, whether that's your oncologist, whether that's your counselor, whoever that is, just check in with them and say, what are you seeing? You know, what are you observing? Because they may be observing things that, you know, you're not as a patient. Okay. And check in with them. So that's kind of doing your homework first, and then thinking about what goals do you have. So if your goal is, I really need an improvement in my sleep pattern, or I really would like to, you know, gain a little more energy, or I would really like to be guided to how I can plan for the next step of my illness. What things do I need to be thinking about? I'm really sad. I'm more anxious now than I was before. I'm not sleeping as well. You know, these type of things is take stock of inventory of what your goals would be. The main limitation right now currently in America is access. It's access to ambulatory palliative care. If you're in the hospital and you have a hospital admission, it's easier and easier to be able to get a palliative care consult, because more hospitals have doctors and nurse practitioners. We're fortunate in Birmingham that we do have the supportive care clinic at Kirkland Clinic. to access. But one of the barriers is access.
And that's so unfortunate. But hopefully in becoming more aware of the resources that, there might be more reach, especially in the areas that it is needed.
Yeah, and through telehealth, there's going to be more opportunities for some institutions, some hospitals. Right before this call, I was doing a palliative care consult at Russell Medical Center for a patient and family that are in the hospital at Russell. That's through a research study, but we do have the ability for one of our supportive care physicians to consult on patients receiving radiation therapy at Russell Medical Center. So that's going to be the future.
And I think that's important, just access, like you mentioned, whether that is in person, whether that is, the pandemic changed the world in a way that we just need more accessibility for individuals, especially those who aren't able to travel or those who are just not able to navigate certain systems that have historically worked. We're having to find those new ways to make things work for us.
Yep.
So a lot of what I heard you saying, it kind of answers a lot of my other questions too, just about the things that a person might need to think about prior to engaging with palliative care. So establishing what stage are you in your life right now? What are some things that you think you need? And those who are caring for you, what are some things that they see that you probably don't see? Are there any other resources that can kind of help educate them on palliative care and things that they should be thinking about prior to making the decision to participate?
I think if you just go out, and there is a website, it's called Get Palliative Care. I think it's GET palliativecare.org, O-R-G. There are some questions, there's some, FAQs, sort of frequently asked questions, things like that. One of the misnomers or things that people realize is, does my insurance, or worry about, does my insurance cover it? So the specialty of palliative medicine is just like a cardiologist, an internal medicine, whatever. Most insurance companies cover, the services of a specialist. So there's no problem, no problem with that. It's not something you have to have a pre-authorization. In the ambulatory setting, a patient does not have to have a physician referral to be able to access the resources. Now, some of the supportive care services like counseling, nutrition, physical therapy, massage therapy, those may require insurance approval, but just to see the specialist of palliative care, it's not a problem. You can, families can self-refer. In the hospital setting, it does require a physician to ask for a consult. Did that answer a little bit of your
It did. And I didn't exactly ask the question that way, but I'm glad that's how you answered it, because knowing, that these are services that you might need, and medical components, insurance components, money is involved when it comes to care and transitions in life. So I'm glad to know that it is covered by insurance.
Yeah, it's reimbursed. It's reimbursed.
And then, and knowing that even those things that kind of trickle down, like you mentioned, massage therapy and all of those other different types of things, like it can be covered, but it just goes through insurance approval. So it really just kind of depends on that person's plan and all of those different types of components.
Right. And that's how you that's how patients can access, those, because we, work in an interdisciplinary team. And I know I see maybe one or two, outstanding physical therapists, on the call. And it's extremely important because lots of, and I see a furry friend on the call too. So those are very important, aspects of healing and wellness, and important because mobility and maintaining lifestyle is extremely important to patients who have serious illness. The patient that I just talked with in the hospital at Russell is 87 years old, and he's had 5 orthopedic or GI procedures since November. And prior to that, he was zipping around. They were driving to, Sedona, Arizona in the car. He and his wife, he was very active. He was very mobile, very, up and going. And since then, he's just it's taken a real, toll. And, the most important person for him right now is an aggressive, physical therapist and nutritionist to get, I think the most important thing that I told him on the call, just as an example for you all, is eat what you feel like eating. Because he said, I've been told I can't eat salt. I've been told I got hyperlipidemia. I'm on this medicine for this. I'm like, eat what you feel like eating. Right now, it's important for you to enjoy the food so that you'll eat, so that you'll get some nutrition back. I'm not worried about your cholesterol, right now as much at age 87 when your legs are weak and you need nutrition. He's like, that's the most important thing any doctor has told me. He said, you don't sound like a real doctor. You don't sound like a real doctor. And I said, well, I'm a real doctor of someone that's 87 years old, whose goal is to regain their mobility, to do that. Now, if you were 57 and your blood pressure was this and your cholesterol was this, okay, I'd put on my 57-year-old doctor hat. But, that's important. But he's adamant. I mean, that's what his goal is. His goal is to get back up and moving. It's going to be hard. Going to be hard for him. And we talked about the reality of that, but it was an extra layer of care. He's not ready for hospice. He doesn't have an illness that's 6 months. He's just, nobody's listening to him. They were worried about his, salt intake, which is important if certain situations, but I said, you just need to be liberal with what you feel like eating. Right now, he's not diabetic, so I wasn't giving him bad information, about that. So, but I do tell diabetic patients sometimes, at this point, we'll let you be a little sweeter. I'm more concerned about you eating and having nutrition and enjoying something than I am, tight blood sugar control. So.
Allowing them to feel human and not have more anxiety around numbers,
Sure. Within reason, within boundaries.
Right. Of course, like don't go out and, go to Cookie Fix and order, a 24 box of cookies because you want some
Come
sugar.
home and eat them all, that night or whatever, But once a week to give yourself, a treat or be a little more liberal. But that's one example. That is another thing that palliative care doctors and geriatricians do is we try to sometimes de-prescribe medications because, as we get in different parts of our journey, we don't always need the exact strict parameters around, this, and this. Our bodies are different. Our goals are different. And, we have so many folks that are on so many medicines, 20 medicines or 15, medicines, and they begin to counteract each other. And sometimes the medicines aren't treating the goals, the patient and allowing the patient to actually get better because we've overprescribed. That was a tangent. I'm sorry, you all.
No, it's okay. It's okay. It's all relevant. It's all very relevant. And it kind of just gives a real life example of some things that somebody can kind of be thinking on, So with that said, I have enjoyed this conversation so much. I've been looking at the call. I know everybody else has been enjoying it too. But before we go, did you have any last golden eggs that you wanted to drop for anybody who might be on the call or anybody who wants to play this back later?
Yeah, I'd be interested if anybody has any questions, or comments. I think that, the thing that I would just recommend, and for all of you who've, listened in for a few minutes to take away is really the specialty of palliative and supportive care is about quality of life. It's about treating patients in a holistic manner. I call it returning the art of healing to the science of curing. Because, if I'm diagnosed with a serious illness, I want to be cured. I want to be cured if possible. If I have a heart attack, I want the latest technology because, I still have some good quality of life, left right now. So sure, I want to be cured if possible, but all along the way, I want to be healed. I want to be listened to. I want to have my family of choice with me. I want to, have good quality of life of what things are important. And so that's really kind of what our specialty does is we try to overlay that element of humanity and that element of healing to be a partner with the science. Okay. So I just, would ask you all to tell your friends, don't be afraid of it. The most common thing that we hear a lot of times is folks and families will say, I wish I had done this sooner. I wish that we had called in the supportive care or the palliative care team sooner. You know, that's the big thing. So, you know, I hate to always work on the negative and say it's not hospice. We do help patients access hospice, which is a wonderful benefit. We do. We work with hospice very closely. But, you know, we work with, you know, as many hospice patients we have 3 to 4 times more patients who are just have a serious illness that want to live a better life. And so don't be afraid of it. You know, look it up, do your own inventory, talk to your family, talk to your closest medical, you know, provider. And what's it going to hurt? I mean, what's it going to hurt?
Yeah.
You know, to see a specialist.
Well, thank you so much, Dr. Tucker. It was so wonderful having you come on and talk about palliative care with us. And we appreciate you sharing that story with us to just kind of help us see it through a realistic lens, you know, because sometimes we can get a whole lot of information and we don't know what to do with it. But being able to get an example of what that could look like for someone who's thinking about how they can benefit from palliative care was really helpful. So I want to thank you for that as well. And I hope that, you know, you continue to give us more information about these types of things, especially as it's continuing to develop. Like you said, it's only been about 20 years. So, I mean, who knows where it's going?
Yeah, and I think that one of the things for the future, Janita, and with you know, your group there at Forge, there's other focused, you know, topics that we can, you know, talk more about, because every one of those disciplines that I talked about could have multiple coffee talks about the benefits of counseling, the benefits of, you know, whole food nutrition, the benefits of mobility, and, you know, physical therapy, the benefits of mindfulness, you know, the benefits of expressive therapies. So, I mean, in pain management, in symptom management, you know, the role of good communication and how to ask doctors questions. You know, that's one of the things that maybe we can come back and do another coffee cup conversation, because we can think about it here, but sometimes when the patient gets in the, you know, room with their oncologist or their specialist, it's like, how do you ask? How do you say, you know, what are the things that I should say, or the questions, you know, that I should ask, you know, which is important, because the physician may have the same reaction. They may say, why are you asking about that? Am I not doing a good job? Am I not treating your pain? Are you not telling me something? Are you giving up? Are you, so there's lots of opportunities to demystify, you know, what palliative
what it could mean. Yeah.
Yeah.
Well, thank you so much, Dr. Tucker. This was great. And y'all stay tuned for some of those things that he just kind of blurted out. He was like, oh, while I'm thinking about it, like, these are some things that we can talk about.
And I'll stay on if you are stopping the recording. I'll stay on if folks have some questions.
Yes, I'm going to stop the recording and then we'll start our Q&A.